Hello everyone, I am Claire Gallois. I am a gastroenterologist and a digestive oncologist in Hôpital Européen Georges Pompidou in Paris. As part of ESDO Learning Bytes, I will focus on Sarcopenia and Cachexia in oncology. Here are my conflicts of interest. The definition of sarcopenia is low muscle mass associated with fatigue, decrease in muscle strength, and limitation of physical activities. Cachexia is a multifactorial wasting syndrome characterized by involuntary weight loss with loss of muscle mass, with or without loss of fat mass, and that cannot be reversed by conventional nutrition care. It has many definitions of malnutrition based on clinical and biological parameters we will see after. These three entities overlap and are generated by decrease in energy intake, inflammation and hypercatabolism, and reduction in activity, themselves caused by the tumor, the treatments, and infections. Sarcopenia and malnutrition are multifactorial with especially inflammatory and hypercatabolic syndrome in cancerology, digestive strictures, cholestasis, exocrine pancreatic insufficiency or diabetes in case of pancreatic cancer, for example, anxiety, depression, the different treatments undertaken with surgery, chemotherapy, radiotherapy. And they can have also many consequences with impaired quality of life, decreased overall survival, increased risk of postoperative complications, treatment toxicities, infectious complications, and an increase in hospital stay and care costs. For the assessment of nutritional status or physical activity level in clinical practice, first of all, for clinical parameters, we use the percentage of weight loss and the BMI with non-consensual cutoff values to define malnutrition or severe malnutrition, but these are often used with, for example, for the diagnosis of malnutrition, more than 5% of weight loss in 1 month or more than 10% in 6 months, and a BMI less than 18.5 for patients under 70 years old, or less than 21 for those over 70 years old. Due to the possible overestimation of the weights, for example by edema or ascites, the measurements of brachial muscle circumference can be useful in these cases. We have also to evaluate the ingesta with a verbal or visual analog scale with a definition of reduction of ingesta below 7. And we can use also validated nutrition screening tools such as NRS 2002 MUST MST Mini Nutritional Assessment for elderly patients, which is sometimes difficult in clinical practice. In total, this clinical assessment must be carried out at the start of the treatment, but also regularly during the follow-up. For the assessment of physical activity levels, the two most used tools are the ECOG performance status and the fatigue visual scale. Other clinical evaluations are useful, such as hand grip tests, repeated chair rise tests, get up and go tests, etc., but are time-consuming. The assessment of body composition is difficult in current clinical practice, but can be performed with dual X-ray absorptiometry, anthropometry, the measurement of skeletal muscle index in CT scan at L3 level, which is quite easy to do by a radiologist, and bioimpedance analysis. For the assessment of nutritional status with biological parameters, dosage of albumin and CRP plasma levels is recommended as the deficiency screening. The moderate malnutrition is defined by albuminemia under 35 grams per liter and severe malnutrition by albuminemia under 30 grams per liter. However, albuminemia is not always reliable and can be lowered by other reasons as biological inflammatory syndrome, hepatocellular insufficiency, nephrotic syndrome, exudative enteropathy, or repeated ascites punctures. CRP over 10 mg per liter is a marker of systemic inflammatory response. And we can also use the Glasgow Prognostic Score to assess this inflammatory response. For the deficiency screening, it is recommended to dose systematically ferritin, transferrin, saturation coefficients, ionogram, creatinine, calcium, phosphor, magnesium, and prothrombin. And finally, the plasma level of prealbumin is useful mainly for monitoring nutritional intervention. So what are the possibilities for nutritional intervention? The recommended intakes in oncology are 30 to 35 kilocalories per kilogram per day, including 1.2 to 1.5 gram of protein per kilogram. Nutritional counseling and treatments of symptoms impairing food intakes as nausea, vomiting, mucositis, etc. are systematic in the patient's management. And if ingesta are under 70%, we have to prescribe oral nutritional supplements. If oral nutrition remains inadequate, we have to introduce artificial nutrition with enteral nutrition as much as possible. If there is a failure of enteral nutrition or an unusable or inaccessible digestive tract, we have to introduce parenteral nutrition with all the risks that this entails, such as catheter infections, venous thrombosis, cholestasis, edemas, etc. We have to be very careful with the refeeding syndrome if oral food intakes has been decreased severely for a prolonged period of time. In this case, we have to increase nutrition over several days slowly and to regularly assess phosphate, potassium, and magnesium levels to prevent it. The patients have to be managed by an expert team if BMI is under 16 or weight loss more than 15% in 3 to 6 months or negligible oral intakes for more than 10 days or a low level of potassium, phosphor or magnesium before refeeding. Finally, therapeutic fasting and restrictive diets are not recommended in oncology because they have no demonstrated clinical benefits and may have deleterious effects on the nutritional status of our patients. For physical activity during chemotherapy, we have to educate and inform the patient on the benefits of physical activity during and after treatment, such as reduction of fatigue, improvement in quality of life, physical condition, and a potential effect on survival. We have to do it from the beginning of the management of the patient and regularly during the follow-up. We can advise resistance exercise in addition to aerobic exercise to maintain muscle strength and muscle mass. Is there a place for pharmaconutrients and pharmacological agents in oncology? First of all, corticoids can be used in order to increase the appetite, but for a restricted period of time, 3 weeks maximum. They are more suitable for patients with a short life expectancy, especially if they have other symptoms that may be elevated by this class of drugs, like pain, nausea, etc. Furthermore, we have to be very careful with the risk of side effects as muscle wasting, insulin resistance, infections, etc. Supplementation with long-chain and 3 fatty acids or fish oil has been shown to stabilize or improve appetite, food intake, lean body mass, and body weight. Prokinetic agents could relieve early satiety, but we have to treat constipation before And we also have to be very careful with the neurologic or cardiac adverse events for metoclopramide and domperidone. Finally, progestins could increase the appetite, but with a risk, non-negligible risk of thromboembolism. Finally, in advanced palliative situations, it is not recommended to initiate artificial nutrition if the life expectancy is less than 3 months. Specifically, in dying patients, artificial hydration and nutrition are unlikely to provide any benefits, as the main objective in this case is the patient's comfort. But we can, in certain conditions, discuss a short and limited hydration after discussion with the patient and his family to rule out dehydration as the precipitating cause. Thank you for your attention.